this session is also being recorded, so we're asking that you to continue to keep your microphones on mute. We'll also have closed captioning for this webinar. To turn it on, click on the CC or closed captioning button in the Zoom control bar. Next slide, please. All participants have been muted. If you have any questions or need technical help during this call, please utilize the chat function in the bottom right corner of your screen. If you have any other questions or concerns during the call, please private message myself or Iman Karnarbi, who is serving as our technical assistant support. We're listed as the host. All questions for presenters will be addressed at the end, but we will keep a queue of your questions, so please send them our way as they come up. This webinar is being recorded. The recording and presentation materials will be emailed to those that are registered, and the materials will also be available on the NCSD website. Here, I wanted to share our webinar objectives for today. This past year, the public recognized the invaluable role disease intervention specialists, or DIS, play in our public health workforce. Highly skilled in contact tracing and linking patients to care, DIS serve as essential frontline workers that are trained in outbreak response and in partner services. In the interim of CDC's Passport to Partner Services in-person trainings being suspended due to COVID-19 and the pending rollout of a new online curriculum being developed, DIS still need specialized training to provide quality partner services. This webinar will discuss how 3 jurisdictions are training their new DIS to consider how state laws pertain to DIS work, conduct timely investigations and efficient documentation on field records, motivate patients to participate in STD/HIV partner services, utilize creative tactics to obtain locating information during partner or contact elicitation, and address barriers that elicited partners have to get tested and treated for STIs and HIV. Next slide, please. Now, I'd like to introduce you to our presenters for today. First, we'll hear from Nikki Baer. She's an STD/HIV prevention specialist from the Utah Department of Health, located in Salt Lake City, Utah. Next, we'll hear from Amber McCarthy. She serves as a lead disease intervention specialist in the Sedgwick County Health Department in Wichita, Kansas. And last, we'll hear from Dagmar Diaz. She's a regional STD program coordinator at the Virginia Department of Health in Richmond, Virginia. So now, to begin our webinar, we'll hear from Nikki Baer from the Utah Health Department. Nikki Baer has worked in Utah's HIV and STD program as a prevention specialist for 2 years. Her role includes providing technical assistance to local health departments, training DIS, and managing congenital syphilis cases. Nikki, take it away.
Hi, thank you, Christy. As Christy said, my name is Nikki Baer, and I'm an STD and HIV prevention specialist at the Utah Department of Health. Next slide, please. And this is the Utah Department of Health's mission and vision. Next slide, please. And these are our strategic priorities. Next slide, please. So Utah is a decentralized state. We have 13 individual health jurisdictions that each hire and train their own staff. This includes DIS as well as public health nurses. So the Utah Department of Health's HIV and STD program began creating a virtual training presentation for DIS prior to the COVID-19 pandemic in the fall of 2019. We wanted to create a central training program to make sure our DIS all had at least the same base knowledge, and then each individual local health department would give more specific training to their DIS. Prior to the creation of this training, DIS relied on CDC's Passport to Partner Services online training, as well as training manuals that were created by our HIV and STD program STD coordinator. Next slide, please. So our HIV and STD program created 3 DIS training presentations. We have a DIS Basics, Syphilis, and Digital DIS presentation. So these presentations were created in PowerPoint and are presented to DIS virtually over a live presentation. So the syphilis and DIS basics training is administered together by UDOH's STD prevention specialist, which is me. And that training takes approximately 2 hours, depending on how long the Q&A session lasts. Our digital DIS presentation is still going through the approval process, so we will hopefully get that up and running and being presented to DIS soon. Next slide, please. So when new DIS are employed at local health departments, that local health department is responsible for emailing the HIV and STD program at the state to schedule a training time. We schedule trainings on an as-needed basis. We do try to combine DIS training into small groups if possible, but we do want to get DIS trained as soon as possible once they have started. So the DIS basics presentation covers confidentiality, Utah laws relevant to DIS work. This includes our minor consent laws and expedited partner therapy. And it also has an overview of interviewing and contact elicitation. During that presentation, we also do a live demonstration of Utah's surveillance system called EpiTrax. And then our syphilis presentation covers testing, symptoms, staging syphilis cases, treatment, interview periods, and managing syphilis reactors in out-of-state cases. And in that presentation, we also include practice case studies. We do not go into depth with gonorrhea and chlamydia in our training presentation, as we have other resources for our DIS to learn about those. However, we do get a lot of confusion with syphilis, as it is a very complicated disease. And so that is why we chose to create a specific training presentation for syphilis, especially as some of our rural jurisdictions do not see a lot of syphilis cases. And so we wanted to give them a firm understanding from the beginning. Next slide, please. So this is an example of one of the slides in our DIS basics presentation going over EPT. So we just teach them about how it is legal in Utah, and then when it's recommended, and just kind of a basic understanding of how EPT works. Next slide, please. And this is an example of one of the slides for our surveillance system. And so we actually go into the surveillance system during the training and do a live presentation. And then we also give them some background information on the system. Next slide. And this is an example of one of the slides from the syphilis presentation. We created these flow charts of the testing algorithms. And we have a link to that in the presentation, so they can use that for reference. Next slide. And this is an example of another slide in the syphilis presentation going over interview periods. We created the visual to help them understand how that works. Next slide. And this is an example of one of the case studies in the syphilis presentation. So there are 5 total case studies to practice. Each one has a description of the patient and their labs at the top, and then the same 4 questions, what the case status should be marked as, what surveillance stage should the case be assigned, how the case should be treated, and what the appropriate interview period is. And we go through these case studies during the presentation, and so they can practice those, and then we discuss the answers. Next slide, please. So prior to developing our training, our STD program coordinator created DIS and EpiTrax manuals that aim to offer DIS a comprehensive resource on our surveillance system and DIS work. So we still use these manuals, and they're a great resource for our DIS. So we send them out to DIS after their training presentation to use as an ongoing reference. And then program staff in our HIV and STD program regularly update the manuals to add additional information and to ensure that they are current. When we have an update of our surveillance system, we will add that into the manual. Also, if we have updates such as the new CDC treatment guidelines, we add those to the manual as well. Next slide, please. So these are examples of what the DIS manual looks like. The first section just goes over what the role of a DIS is. Next slide. And this is an example of what the EpiTrax manual looks like. So it has screenshots of our surveillance system and then step-by-step instructions on how to perform each function that DIS need to know how to do. Next slide. And so as part of our training, we created a pre and post test in order to evaluate the success of our training. So the pre and post test contain 15 multiple choice questions on content from the training. So these questions are the same. There's the same questions and same response options for both the pre and post test. And then the post test contains an additional 6 multiple choice questions and 3 response questions evaluating the presentation. So here's an example of one of the questions, just asking what is expedited partner therapy, and then it gives them 4 response options to select from. Next slide. So we were quite happy with our pre and post test results. So out of 15 new DIS trained since the development of the pre and post test, 14 completed both the pre and post tests. The average pre-test score of those 14 was 7.2 out of 15 possible points. And the average post-test score was 13.5 out of 15 for an increase of 87.5%. Next slide, please. And so in addition to our HIV and STD program training, each local health department determines what additional trainings their staff should undergo. Some have more comprehensive programs, and then others just include shadowing other DIS during investigations and nurses during clinic visits. So that shadowing ensures that they do get some more live experience on how to conduct investigations. So our HIV and STD program does strongly encourage DIS to complete the CDC's Passport to Partner Services online training to make sure they have more in-depth knowledge on interviewing techniques and other DIS skills. Next slide, please. And then that is the end of my presentation. Thank you so much. And there is my contact information.
Thank you, Nikki. That was such a great presentation. If you have any questions for Nikki, please feel free to drop those in the chat. We'll be addressing those at the end of the webinar. Now, I'd like to introduce you to Amber McCarthy. She's going to share her experience about providing training to DIS during COVID-19. Amber has been a DIS for a little over 5 years at her local health department. As a lead DIS, she provides case guidance and investigative support to her team of DIS, as well as manage a caseload of syphilis and HIV clients. When not busy investigating, Amber also works on quality improvement projects for her health department. Amber, take it away.
Thank you so much, Christy. So I've put together a quick PowerPoint about some of the things that we do in order to train our DIS to help them in conducting like their partner services and their investigations. Go ahead and go to the next slide, please. So in 2018, that was about 2 years into me being a DIS, it was taking us an average of about 7 months to get a DIS completely through training, because we have pretty intensive training because we want our DIS to be specialists. So in 2019, I decided that we needed to try and improve that timeline because that was really hurting our turnover, because taking 7 months to train someone before they can do a job was making it really difficult to maintain our caseloads when so many people were always in training. So I collaborated with my other organization, the Kansas Department of Health and Environment, in order to develop a more comprehensive training guide to try and help focus people's time and efforts to accomplishing things that they need to be able to accomplish as a DIS. So in 2020, we created the Kansas DIS training guide and released it and implemented it. Now in 2021, the average length of training for a DIS is 4 months. So we managed to shave about 3 months off of that. I know it's still a long time, but for us, that's pretty good considering the level of proficiency our DIS have at the conclusion of that training. Next slide. So whenever we created this training guide, we decided to break it down into what we called core competencies. So what are the real basic functions of what an investigator does? So we identified these 8 basic categories: Trisano or EpiTrax, which is what Utah uses apparently too, which is what we use to document our cases. general disease knowledge, conducting interviews, phone calls, field visits, investigations, collecting specimens, and community collaboration. Next slide. So within each of those categories, if you were to take a look at our training guide, which there's a little picture of it on the right, you would see that each different category has its own objectives. And within those objectives, it has actionable tasks for the trainee to complete. And hopefully, whenever they complete those things, they are going to be competent at that objective. And you'll notice that we also color-coded our manual. So things that are green, like you see on the right there, are tasks that the DIS can independently complete. Things that are colored blue are things that they would need their trainer to help them complete. And then there is one red item on there, and that would be an item that someone outside of our program helps them complete. And so each succeeding level within that training guide is supposed to get a little more complex and involved for the trainee. So it's supposed to build skills over time. Next slide. So we're going to look at 3 of these categories to focus on some of our objectives for this presentation we're doing today. So we're going to look a little bit closer at our interviews, phone calls, and investigations. Next slide. So by looking at those 3 categories, my goal for today is to understand how we motivate our patients to participate in partner services, which we do in our interview section. We're going to talk about how we utilize creative tactics to obtain locating information, which happens during our investigations. And then we're also going to discuss how we address barriers that our partners usually present to us when they don't want to get tested or they don't want to get treated, and how we might navigate those barriers. Next slide. So first and foremost, motivating our patients to participate in partner services. I think we all know the importance of having someone interviewed and getting that buy-in for them to give us their partners so we can reduce disease burden in our community. The way that we teach our DIS to do that is kind of 3 categories. So initially, we're going to introduce the concepts of an interview to them. We're going to establish a foundation for interviews, and then they're going to practice those skills. So in order to introduce the concepts, we use Passport to Partner Services on the train.org. So we have them go through one because they need disease knowledge in order to do an interview. And then they also need that Passport to Partner Services for kind of an introduction on how they might format an interview. While they're completing that Passport to Partner Services, because it's a lot of computer work, we do allow them to shadow with their trainer so that they can kind of get introduced to what we call a live interview. And when they're doing those shadowing, they're actually completing an audit form. So they're checking off saying, oh yeah, I saw my trainer complete that task. I saw my trainer talk about that. And you'll see that audit form in just a second. So whenever we're establishing the foundation for interviews, that's when we're going to have the trainee doing mock interviews with their trainer. Now, when COVID happened, that kind of changed how we were having to do that, because a lot of people weren't comfortable meeting in person face-to-face to do that sort of thing. While that's the easy way to do it, we did also have some success in scheduling Zoom mock interviews with their trainer. So they would conduct an interview basically like they would in person, but they would just use a Zoom format in order to do that. Of course, once everyone was vaccinated, then we had more of an opportunity to meet in person. We have 12 DIS across the state of Kansas, so we're kind of dispersed. So for us, it was helpful to have Zoom as a tool, because traveling took up a lot of time. Some people would have to drive several hours in order to go meet with their trainer, and that wasn't ideal either. So we were pretty excited to get to use Zoom in that capacity, and shocked that we hadn't thought to do that sooner, honestly. So once the trainee has gone through a series of mock interviews and the trainer has given them feedback multiple times, once the trainer feels the trainee has sufficiently met kind of a baseline of presenting information accurately, then they're going to go into live interviews. So they're going to meet with real clients, but their trainer is going to be shadowing them instead, filling out that same audit form. Next slide, please. So here's just kind of a little sample of it. It might be small, I apologize. I'm happy to share it if you guys need me to. We have audits for basically everything we do, from interviews, field visits, phone calls, case documentation, phlebotomy, because we teach our DIS how to draw blood if they don't know. So we like audit forms here. The trainer and the trainee are going to use this exact same audit form whenever they're learning so that the expectations remain consistent. So the trainee is going to fill out this audit form whenever they're observing, and the trainer is going to complete the same audit form during a mock interview or during a live interview. So many of these interview expectations are going to help the DIS build confidence in interviewing clients, and it's also going to help them establish a positive relationship with the client so that they trust the investigator to help them. So that's one of the key ways that we do motivate people to participate in partner services. If the client likes you and trusts you and wants to talk to you, they're a lot more likely to give you partner information. So that's why our audit form doesn't just focus on, did you say this thing? It talks about, did you build rapport? Did you listen to them? Did you ask questions? Because those things are important to us. Next slide. So again, kind of the main way that they're going to learn how to do this skill is through practice. We do a lot of mock interviews. So when our trainers do mock interviews with their trainees, we want to make sure that their mock interviews are helping the trainee address certain barriers that we hear a lot. So 3 of the ones that we kind of focus on, because once you've been a DIS for a while, you've probably heard this a few times. So the first one is that they're concerned about their privacy. I don't want my partner to know I have this infection, or I don't want them to blame me for giving this infection to them. The second one is a dislike of government. They don't think we should be involved with their life, with their sex life, with their health. And then also concerns about safety. Sometimes we do have patients say, like, I don't want you to talk to this person because they might hurt me. They may be upset that I have this disease or whatnot. Next slide. So this is just kind of a couple of the hot points that we might use whenever we're counseling our trainees how to handle those situations. So there's obviously a number of situations that could come up, and that's one of the reasons I love this job, is because it is so different, but it does make our investigators feel a lot more confident when they have talking points that they can fall back on whenever they hear one of these trigger phrases. So for instance, if someone says they don't want to be blamed, we might reiterate to them that they're at risk for reinfection if we don't get their partners taken care of. I feel like it helps a lot whenever I review my privacy policies, and maybe even demonstrating how I might notify those partners so that they get a sense for how that conversation is going to go. Usually makes people feel a lot more comfortable. This isn't any of your business is one of the harder topics, because people tend to be kind of set in their ways when they're saying something like this to me, and that's fine. They have the right to refuse my services. I'm still going to remind them that they're at risk for reinfection if I can't ensure their partners are taken care of. I might offer what we call contract notification. You guys may know that term if you've been a DIS. So that's where you will say, let's talk about your partners and how you tell them to reach out to me. And if they don't reach out to me by Friday, then I'll start reaching out to them. Sometimes we'll also discuss how complicated syphilis and syphilis care is, and that a lot of physicians don't understand all of the services that their partners are going to need. So while you may be willing to notify your partners, I'm able to help ensure that they get all of the care that they need, such as preventative treatment. And if all of that fails, then usually we'll kind of fall back on, here's my contact information. If you change your mind, please call me, or if you want to give my contact info to your partners so that they can call me directly, I would love to hear from them. And then the last one is, I'm worried that my partner will hurt me. My favorite question of all time is asking why. I like getting more information. It may be something really serious, or it may not be something serious. So that's going to help me gauge my next steps with that client. Again, discussing their risk for reinfection. That's a big theme for us, is trying to get people motivated to disclose their partners. And then I'm also going to offer community resources if I feel like they really are at risk. If they're in danger and they want to accept services for being in danger, I want to help connect them with that. And, you know, I always have to be willing to accept that the physical danger for that person might just be too great for me to elicit their partners and get in contact with their partners. Next slide. So the next thing that we like to train our DIS is to utilize creative tactics in order to obtain locating information, because a lot of times those basic questions aren't going to get us what we need. People connect in different ways. You know, they use the internet to meet up. They meet up at clubs. They meet through friend of a friend, or however it is they go about meeting their partners. So always asking for name, phone number, address, while helpful, doesn't always get us what we need. So in order to help our DIS with that skill, the first thing that we do is we help them identify investigation resources in our area. So that could be, you know, using the internet like Facebook or whatever. Or we also have a Kansas Health Information Network. So all of the hospitals report people's medical records there. The second thing we're going to do is we're going to model critical thinking. So that kind of falls again into me being audited by that trainee so that they can see why I'm thinking of asking these questions. And I'm going to make sure at the end of that interview to discuss that with my trainee, to say, did you notice how I asked these unusual questions? This is why I did that. And then the third is letting them practice with those resources and locating partners and crossing over information to verify you have the right person. Next slide. So like I said, our resources includes a lot of different things. Some of the more common ones that we use dating apps like Tinder and Grindr. We use social media like Facebook and Instagram. And then we, sorry, my dog. And then we also like to use Google Maps is one of my favorite ones to use, especially when the client is like, oh yeah, they live over at the intersection of 21st and Mays. Usually if I pull up Google Maps, they can get me to that house and I can screenshot it and know what house I need to go to. So I'll get a physical description and go to the house and look for that person. Next slide. So like I said, we're going to model critical thinking by being examples, asking more complex questions. And we also have our trainees review a PowerPoint we put together about internet-based investigating. So it talks about how they might link things together, how they might verify a contact. Next slide. And lastly, we're going to have our trainees use Facebook. We're going to verify they found the right person. We're going to have them research in the Kansas Health Information Network to identify emergency contacts. Or I'm going to have them use Google Maps with a client to find a client's home. Next slide. So lastly, addressing barriers that our partners have to getting tested. So first thing that a DIS is going to do in their initial stages is they're going to shadow a trainer and hear how that flow of conversation goes. They're going to next review our overcoming objectives guide that we created, which I'll show you on the next slide. And then they're going to practice in a mock scenario, calling partners in order to notify them. And the trainer is going to present an objective pretty much every time they call. Next slide. So this is just kind of part of our overcoming objections guide. I know when I first started training, I was really anxious about making those phone calls and not knowing what I was going to say if that person told me no. And so I hashed it out with my trainer at the time, and then I decided to just create a list so that people could use this in the future. So for example, you know, someone might say, I don't have sex. So I will probably explain to them how syphilis is spread. We like to give them a way out because sometimes they don't want to admit that they're doing those things. So we might say, well, it's deep kissing, skin to skin contact. Technically you could get it through massages or something. Or if they say, I don't have money, we respond, well, it's free. And then we also have our trainees come up with their own objective to add to this list. Next slide. And that was the whole thing. So those are some of the basic things that we do in order to help prepare our DIS to be successful investigators. So thank you for your guys' commitment and attendance at this. I think we have one more presenter that Christy will introduce now. There's my contact information if you need it.
Awesome. Thank you so much, Amber. That was amazing. Last but not least, I'd like to now introduce you to Dagmar Diaz to share her experience training DIS during the COVID-19 pandemic. She started working with the Virginia Department of Health as a DIS in 2015, and in 2019 became one of 6 regional coordinators for the STI program. Dagmar has also been working for the STI field for 20 years. Dagmar, welcome, and the floor is yours.
Thank you, Christy. Thank you, everyone, and thanks for joining us for this training or for this talk. So we were faced with some difficult training when it came to COVID and not being able to meet in person. So our field operations and training coordinator aptly trained our messaging of orienting and a disorienting time. So what I'm going to do is I'm going to kind of go over how we have been training in-house our DIS in the state of Virginia without the use of the CDC passport class for them to go to. Next slide. So this is just a quick overview of what we were doing before, and I think it's safe to say that most programs were doing the same thing prior to COVID. So when DIS were coming in, they were completing passport to partner services online modules. If you've been a DIS, you know how tedious those modules were and how long it took us to get through them. We would sprinkle in some shadowing of experienced DIS with the new DIS. They would go out to field with the experienced staff member. They would also shadow in clinics for those who worked in a local health district in the clinic. Typically, they would travel to one of our high morbidity areas. For example, where I'm at in the city of Richmond, we have a lot of morbidity as the state capital. So that was a great ground for people to come and spend a week with us to kind of see how we work in a high morbidity area. We would orient the new staff or the new DIS to Virginia specific aspects. So interpreting the labs from our state lab and what to look for, the laws that are specific, not just to STIs and HIV, but also what laws are specific to the state of Virginia. We would look at policies and procedures, not only again for the state, but also looking at what is the policy and procedure for their specific jurisdiction. And then we also had them review the field operations manual. We call it the FOM. I like to call it the DIS Bible because if you're looking for information, you can look there. You should be able to find it in that field operations manual. After all of this, and after some time, they would attend the in-person passport class. After the course, they would then shadow the experienced DIS in their jurisdiction a little bit longer, and then they would be signed off either by their regional coordinator or they would be signed off by their supervisor in their jurisdiction. And then once approved, they would start investigating cases of syphilis and HIV, and only once they completed all the training modules in the in-person class. Next slide, please. So during COVID, we were facing the challenge again of we have no more in-person training from CDC. The state of Virginia, like many other states, was not allowing any training in person. So we couldn't even gather together here in Richmond to train staff. For Virginia, we also weren't allowed to travel out of the state. So state employees were no longer allowed to travel out of the state of Virginia. And we kind of localized, unless people were working for COVID, they were not traveling out of their jurisdiction. Many of our DIS were also reassigned to COVID work. So we know how great and what a great impact the DIS have had with COVID. They were also being pooled for their expertise in working COVID investigations. However, we still needed to get new DIS trained and we needed to get them functioning quickly so that we can support the operations of HIV and STI while the experienced DIS are supporting COVID operations. At that time, we were also not doing any in-person interviews. So I will say that did present a little bit of a challenge when it came to hiring individuals. Next slide, please. So our revised training plan. So with our training coordinator and with some of the regional coordinators, we sat down and said, what can we do to get our staff trained? We can't have somebody be in training for over a year. We didn't know how long COVID was going to happen. So we had to kind of take matters in our hands. So what we did was we developed our own passport style training class, was also a week. Unfortunately, they didn't get to travel to cool places like Kansas, Utah, or Connecticut, where I got to go. But we did go ahead and develop a week-long virtual class for them to attend. The first class was conducted in December of 2020 and consisted of any DIS staff that was hired from around September to October. And the class, we conducted the class one other time since December, and we are getting ready to do a third virtual class in about 2 or 3 weeks. currently doing the course virtually, but we are hoping to start it again in person depending on what this Delta variant brings us. Next slide. So our training plan. Upon hire, we would have the DIS start looking at the Passport to Partner Services online modules. This included the enhanced modules released by CDC, which also included PrEP, conducting telephone interviews, field safety, public health detailing, trauma-informed care, and et cetera. I think there was a good number, probably about 6 additional modules that they have gone through. They would have weekly check-in with one of the regional coordinators, such as myself, and we would assess progress. We would answer their questions. We would look at how we're going to integrate what they're learning into daily work. And then what we did is we also started breaking down the interview format for them. So we took it into baby steps a little bit each week when we met and break down what that interview format was so that they had an understanding of why we're asking that and then how to put it in motion. They have the opportunity to visit other health departments. They have the opportunity to work with experienced DIS. If they're lucky to be in a team of DIS in their specific jurisdiction, they can work amongst each other. Many of our DIS work as a one-man show. So if they were able to, they would travel to Richmond or they would travel to another morbidity, high morbidity area so they can shadow that DIS. They got to listen to the interviews being conducted over the phone because unfortunately at that time we were also not doing in-person interviews. And they could shadow them in the clinic as well. They attend the virtual class to enhance their interviewing skills. And then we also do a lot of talking about motivational interviewing and motivational techniques to, as you've heard the other presenters, motivate them to accept partner services. Next slide. So for the virtual class, what did we create? We don't have that really fancy big binder that Passport gave us. We all have it all electronically, which is a little bit different, but we created a lot of role plays. I believe Amber said that they do a lot of role playing. They do a lot of mock interviewing, and that's music to our ears here in Virginia because we do a lot of role playing and a lot of mock interviewing as well. If any of my DIS are on the call, they may not find that as fun as I do. So each of the role plays had a different challenge, such as motivating the patient to provide information on partners, maybe giving us information on partners from other states. We're close to North Carolina. We're close to, some of our DIS are close to Tennessee. Some of us are close to Maryland and DC. So motivating them to give us that information. And of course, how to work with the patient who says, I'm going to tell all of my partners, that's my responsibility. So how do we motivate them? Instead of just giving up and saying, great, I'm so glad you're going to tell all your partners, we really work with them to devise strategies to get that information so that we can obtain the partner and again, ensure that they're actually getting what they need. We also created 6 field scenarios designed to help the participant learn what they may approach. And I think Amber had a great picture of that on her presentation. So we also try to think of the what ifs. And yes, if you're a DIS for any amount of time, you know what those what ifs may be. We can only try to anticipate them, but you know, we try to provide as much of an anticipation for them as possible. So what if you roll up and it's an unsafe situation? What would you do? And we, you know, kind of do this in a round robin style as a team and as a group together to ask, what would you do? And then we might ask the next DIS, what would you do if you were going to someone's home and it's an unsafe situation? What about encountering that parent? You got to go tell a 16-year-old they're a contact. What are you going to do when mom will not let you talk with their daughter or not let you talk with their son? So we kind of work through that barrier, and it's really fascinating to see the parents on the call give some suggestions. It's fascinating to see individuals who have been DIS for a while give their suggestions as well. And then of course, the patient who's not motivated to come in, you know, they've told you they're coming in, they're told you're coming in, and it's been a month and they still haven't come in. So what do we do to get them motivated? So these are what the 6 field scenarios really work for. And again, we do talk about those as a group so that we can share different ideas of what might motivate a potential patient. Next slide. So what's the format? What does it look like? So we have 2 weeks of training. The first week is an overview, of course, of partner services and what the benefits are. We have discussions again on using open-ended questions, using motivators, active listening, utilizing Lover. We again talk about that interview format. We pretty much want to drill into them the interview format because we know that it's proven to work. So we want to make sure that they're following that interview format. We break it down. Not only have they been practicing it with their individual regional coordinator, but they're also practicing it bit by bit, piece by piece, with one small role play at a time during the training class. And of course, as always, discussion of overcoming the barriers and what motivational techniques we can use. Next slide. We also have full role plays of a full interview that they get to practice. So role play number 1 is on patient number 1. We utilize one of the coordinators or an experienced DIS gets to play the patient, and I apologize, there's a squeaky toy in the background. So we play the patient and we then provide feedback to the DIS on things they did exceptionally well, and then things that we can provide examples that might work a little bit better next time. We all use separate call-ins, so it's a lot of navigating back and forth on Google Meets, but calling each other and doing role plays. Instead of breaking into small groups in person, we do them virtually. We then come back as a big group and we do a post-interview analysis of the role play. Once we've talked about that, we will do a full role play on patient number 2. And patient number 2 happens to be the partner of patient number 1. So now they got a partner, now they're role playing with that partner. So they get to go from OP to P1. They get to see what that is like, and they get to see how that helps to develop their case. We come back together, we do a post-interview analysis on the second role play. And then we also get to talk about what a role play re-interview looks like. And we actually do that again, round robin style, where we'll pick on one DIS and say, okay, you ask the next re-interview question, you ask the next question, you ask the next question. So as a group, we will do that re-interview. Next slide. They also get a chance to talk with the HIV surveillance team. So they do some database training. Here in Virginia, we use Maven. So they learn how investigations are assigned and they learn how to enter cases into the database. One thing that we do is that we go ahead and after we've interviewed patient number 1, number 2, we hold on to our notes, and now we're going to enter patient number 1 into Maven. So that's, again, allowing them to see that process all the way through from interviewing to getting the partner to now entering it into our database. Visual case analysis training also takes place. So we have our CDC advisee sits with them virtually, goes over the case analysis. We have symptom information that we're able to plot for ghosting of lesions. We discuss potential source and spread, and we're not just bringing these up from anywhere. If you guessed it, we're using it from role play number 1 and role play number 2. So kind of building off of what those role plays were into our VCA. Next slide. The final role play is with either the regional coordinator or with the frontline supervisor. So we made this role play pretty complex. We threw everything at them that they potentially have learned throughout this week. It serves as their sign-off interview, mock interview. And again, we made it complex. We don't expect that every person is going to be able to get every piece of that. But again, we're kind of working to see, are they able to work with the complex situation that the patient brings forth? Are they able to motivate them using chart or using what we've taught them? Are they using open-ended questions? It allows the DIS to become more comfortable as well with the interviewing as we're doing it day by day as we're doing our training. Once they are signed off by that frontline supervisor or the regional coordinator, they will begin to receive investigations typically by the next day. So they start receiving syphilis and HIV interviews at that point. Next slide. And I will say that they are constantly receiving support from Their fellow DIS that they've already been training, we typically have an experienced DIS mentoring a new DIS. And of course, they have the support of their supervisors along with the 6 regional coordinators. Week number 2, they're going to learn a lot more about the staging of syphilis. We know how complex that can be. We throw different scenarios at them and we look at what staging of syphilis looks like. We also introduce standards of investigation and the performance metrics. So what are we looking for? The why. A lot of our DIS want to know why. Why do we have to turn this in this amount of time? Why do we need to close our field record in 7 days? Why can't we just make one phone call and say unable to locate? So we look at all of that together. And then we introduce with them with other work units, not just that are in our program, but that they will be interacting with on a regular basis. So such programs as our HIV and hepatitis program, Ryan Whiten HIV Care Services, the surveillance team, and the cluster detection and response team. So they get to meet them and they find out how they will work closely with them. Next slide. And then the benefits of the local training is that we're able to incorporate very specific aspects to our state here in Virginia. We get to reference our field operations manual throughout the training, and we highlight the specific metrics and again, the reason behind them. It allows us to really hone in on the timely investigation, why that's a concern for public health, and why we're, as supervisors, we're not just on them to say, get this into me, but why that really makes a difference in public health. We ensure that role play reflect the real challenges that we're seeing around here. We take input from DIS. All of the regional coordinators have been DIS at one point. So we use what we've learned throughout the years to make our role plays for the training. And then again, we're incorporating collaboration with our other work units because we're not just a siloed team, but we're working within a bigger team in Virginia. Okay, next slide. Nope, that was it. So I thank you guys for your time. Kendra Weinling is our field and operations training coordinator. She was unfortunately not able to make it in today. That is her contact information. So if you do have questions that I can't answer during our question and answer, you can reach out to her. Thank you.
Awesome. Thank you, Dagmar. And thank you to all of our presenters. Now we'll take a few questions from the chat box for presenters. Please feel free to continue to submit your questions if you haven't done so already while we are chatting. So it looks like this question would be appropriate for all of our presenters. How long is your shadowing period for the DIS? And any of the presenters, please feel free to jump in and answer.
So our shadowing that we do is based on how quickly they can accomplish the different types of shadowing. So on that training guide, there's going to be a shadow A710, so a primary syphilis, shadow A720 or a secondary syphilis, shadow a P1 to 700, shadow a P1 to 900. So we want them to see a variety. And it may take a while for all of those things to happen. We have a lot of cases in my county. So in my county, it doesn't take long for that to happen. But in another part of the state that maybe doesn't have quite as high of a morbidity count, probably going to take a little bit longer for them to accomplish all of those shadows. But we want to make sure that they're meeting all of those. So it comes out to be about 6 shadows that they need to officially sign off on.
And I will say here in Virginia, we don't quite have that structure of a timeline with our DIS. I think some DIS learn a lot quicker than others. So we kind of take an approach of, and as Amber said, some areas have higher morbidity. So you might see all of that in 1 week, where another DIS in far Southwest, it may take them 3 or 4 months to see an interview for a primary syphilis. So we kind of tailor it to where they're at. But one thing that we do is, whenever possible, we had them go out once a week and shadow a DIS out in field, out in the clinic. If they're, like I said, if they're lucky enough to work with another DIS in their office, they're oftentimes calling them and saying, hey, I've got an interview, come on in and listen, and they're working closely with them. So for us, it kind of depends on the DIS and where they're at, but typically a couple months, and then sometimes they may still request some more shadowing after their passport style class if they're not fully comfortable. So they kind of have they partner up like a buddy system, and they may work that way with the DIS or with one of the regional coordinators.
Awesome. Nikki, did you want to respond? Go ahead.
Yes, so for Utah, it varies quite a bit since the shadowing portion of training is done at each local health department. Only one of our jurisdictions has STD-specific DIS. The others have public health nurses who work many diseases. So the shadowing kind of depends on, again, it varies in each county, but it also depends on whether they're STD-specific or if they're a public health nurse. They do a lot more shadowing for other diseases as well as STDs.
Thank you. Going down in the chat box, Myra and Mariska mentioned, Amber, if you could share a copy of your audit forms and your phlebotomy training plan and that audit sheet for that portion.
Yeah, I can totally share those. Kansas is lucky for the phlebotomy part because we don't actually require certification to do venipuncture in the state of Kansas. Other states are going to be different and they're going to require you to get certified. I'm not certified, but I am the phlebotomy trainer. So I teach our DIS how to draw blood because I've been doing it for so long. But yeah, I can also definitely share some audit forms. I'm sure Christy could send those out.
For sure. Awesome. Great. We have another question. Are online anonymous notifications like InSpot, tellyourpartner.org, and stdcheck.com still being used by DIS when people don't want to share information? I think that question might have been towards you, Amber, when you mentioned the creative investigation resources.
We will let our clients know that that is an option. They can use like an anonymous notification system. DIS ourselves don't use those because if we have a phone number, we know who the contact is. So we're going to research it and figure out who they are. But then we do use like Grindr and Facebook to send messages. We create profiles that have like the state of Kansas logo on it. And we send a very scripted message of, I need to talk to you about an urgent health matter. Please call me as soon as possible at the number below. And then we don't really discuss information further over a messenger unless they call us. Then we will tell them you're a contact to syphilis or you're a contact to HIV.
That's super helpful. And you just answered the follow-up question, which is how do you use the dating apps for a partner and contact elicitation? So thank you for sharing that. And I'll just pause if the other presenters have any, if you'd like to respond to that as well, if you all use dating apps at all for partner contact elicitation or any other social media platforms to connect with contacts.
So we're in Virginia, we're actually in the process of putting together an internet partner services tool. So we are to be coming. So I may reach out to Amber, we may reach out to you and see how you're doing and what tools you guys are using and procedures. One thing we did develop as a pilot program is we used cards that we developed so that when a patient told us, I don't want you to tell him or her, I'll have them contact you, we gave them a card and we would say, well, here's this card. If they're interested, they can call. Here's the number to their closest local health department. My information is also on there as a DIS. Or if they just want to show up to clinic and present this card, then we'll know why they're coming in. And we would instruct our front office staff and our nurses that meant they should be tested specifically for all STIs because it didn't have information on this person as a contact to this infection. So we would hope that the OP or the original patient would tell their partner, but if they didn't, we were still covering it by saying test them for all STIs. And I don't know that the results of how effective that was have come in, but I know that a number of partners who use Grindr or other apps who said, I have anonymous partners, I don't know, they would take a picture of it and send that to their partner so that they could then, and some people would come in and say, here's my phone, you see this card, this is somebody told me to come get tested. So we were able to utilize that.
That's super helpful. Thanks for sharing.
Yeah, and like Dagmar, we are still in the process of creating our Internet Partner Services Toolkit. Well, it has been created, but it hasn't been distributed yet since it's still in the approval processes. Essentially, just in our DIS Basics presentation, we go over what Internet Partner Services is, And we talk about how we do have scripted messages ready for DIS to send to contacts, and also discuss how Internet Partner Services is used to just get the contacts to come into the clinic or to call the DIS, and not to be used for actually notifying partners of their specific exposure.
Awesome. That's great to hear. Thank you. Matthew asked a question. I think this is towards Amber. You said that one of the big areas of focus are in-depth disease knowledge. Do you have additional materials that help detail the signs and symptoms and treatments for each disease?
So we use Passport Partner Services, of course, and then we also use the Green Book. I don't know if any of you know what the Syphilis Green Book is, but it's from like 1940, and it has a lot of information about syphilis and the symptoms. Another tool that we recently started using is New York created a really awesome provider guide. It's like 150 pages. It's called the Diagnosis, Management, and Prevention of Syphilis. And it goes into so much awesome detail about the symptoms, about understanding labs, and all kinds of really cool information that would help you guys educate your investigators as well.
Awesome, great. Amber had asked this question to Dagmar, but I'm going to pose it again. What are your new DIS working on while they wait for your virtual training sessions to begin?
Yeah, so what they're typically working on with any new agency that they're going to, they have onboarding training that the state requires of them. So they're trying to get those, and typically they need to get those done within 30 days. So they're working on their onboarding training. Like I said, so they're not just sitting in front of their computer, just doing training 40 hours a week for, a month or two. We also sprinkle in going out to the field. We also sprinkle in some of our state trainings, like the HIV facts and fundamental classes. If it's available, they will also go to the motivational interviewing class that is offered by the state. So they're doing some other types of interactive training as well. They're meeting with other DIS in their region. When we were in person, they were going to the state office and meeting with the personnel there at the state office, so they could put a voice with the name, especially for those who are not here in Richmond. But virtually, they're kind of doing that and meeting other DIS in their jurisdiction. So a little bit of that, and then, like I said, a whole lot of training with their regional coordinator. I usually set up 2 hours at a time to work with them so I can answer their questions, because they've got so many questions when they're first training. So I take the time to answer their question, and then we do my favorite role playing.
We love role playing. Thank you. Awesome. Well, looks like we have, doesn't seem like we have any other questions in the chat. I want to thank everyone for joining today, and thank you to our great speakers for your time. Iman is going to drop a link into the chat that will be our survey link. Please complete this evaluation after the webinar is ended, or you could start right now in order to inform future webinars. The recording and the slides, along with other materials, will be sent out to all those that registered, and it will also be placed on our NCSD website. We also have a DIS community on My NCSD. My NCSD is an online community exclusive for NCSD members. So this special DIS community is where you can share resources, discuss challenges, share tips, post questions, and connect with other DIS all over the country. So that link will also be dropped into the chat. Thank you all for your engagement today, and we're super happy to have had you all. Have a wonderful day. Thank you for joining this webinar. Thanks. Bye, everyone.